let's look at section 10, diseases of the stomach. Diseases of the stomach. This session, we are looking at acute abdomen. Once we are able to look at acute abdomen, gastritis and then gastric ulcer may also be discussed, but acute abdomen covers almost all the conditions in the abdomen, including gastritis and the gastric ulcer, because the manifestations under acute abdomen are able to cover specific conditions like gastritis, gastric ulcer, and the rest. So these diseases are discussed in relation to definition, signs and symptoms, pathophysiology, and medical as well as nursing management. So at the end of the session, the student should be able to explain factors that enhance the protective functions of the gastric mucosa, distinguish between causes and signs and symptoms of these diseases, describe the medical and nursing management for these conditions, and then identify and then describe predisposing factors for peptic ulcer. So the topics going to be discussed include acute abdomen and then peptic ulcer. Acute abdomen. Acute abdomen is sudden onset of severe abdominal pain, which may require surgical operation, and it can result from any possible organ that is affected in the abdomen. So possible causes include inflammatory conditions like appendicitis, perforations. We can think about typhoid perforation. We can think about traumatic perforations, intestinal obstruction, strangulated hernia. So when we say acute abdomen, it covers all the conditions. We have hemorrhage, ruptured ectopic pregnancy, ruptured spleen, acute pancreatitis, medical conditions like gastroenteritis, gastritis, renal diseases, and then even nephrotic syndrome. Clinical manifestations of acute abdomen: pain, gradually increasing abdominal pain suggests inflammation, and then it's sudden in perforations. We have absolute constipation, which may also suggest intestinal obstruction. We have nausea and vomiting, which may also occur in acute abdomen, and then fever, and then headaches and sudden abdominal pain may suggest typhoid perforation, and the dizziness or faintness or collapse may also be due to bleeding from ruptured ectopic, ruptured spleen, or liver. And then vaginal discharge may suggest pelvic infection, for instance, the PID, pelvic inflammatory disease. So if you remember, when we were looking at the anatomical divisions of the abdomen, we divided the abdomen into 4 major quadrants, the two upper quadrants and then the 2 lower quadrants. So I indicated that in each of the quadrants we have specific organs. So once you are able to identify the quadrants and there's organs that are located or situated in these quadrants, then when there is a problem, we can specifically pinpoint an organ which is affected. So it's very important that you refer that when we are looking at acute abdomen, to be able to identify specific organs in the quadrants that may give rise to acute abdominal manifestations. So frequent and then dysuria may suggest urinary tract infection, and then a past history of alcohol ingestion may suggest gastritis or acute pancreatitis, and then signs of dehydration. For instance, we look at the dry tongue, sunken eyes, and then that are all part of the manifestations of dehydration, either from vomiting or from diarrhea, and then other factors. And then high temperature in acute inflammations, and then we have abdominal distension with fluid or gas may also suggest peritonitis or hemorrhage. And then absence of bowel sounds points to peritonitis, and then paralytic ileus. And some kind of investigations that we need to do. We have examples here: full blood count, blood film for malaria parasites and others. We have the plain abdominal x-ray for distended abdomen due to intestinal obstruction. Gallstones or kidney stones may also be identified. So, and we can also do chest x-ray for signs of gas under the diaphragm in perforations. For instance, in typhoid perforation, or even appendix which is perforated or ruptured, and for signs of pneumonia as well. And then we can look at the 4 quadrants abdominal tap may yield pus for perforations or blood from bleeding ectopic pregnancies or ruptured spleen or even liver. There are other tests that we can do. And in acute abdomen, treatment may be specific but point to a generalized manifestation. So treatment objectives, we have to be able to resuscitate the patient, to relieve pain, to control infection if it's suspected and if it is present, and then to treat the underlying causes. Here we have the non-pharmacological treatment, and there may be the need to pass NG tube and aspirate the stomach content in the first place. So in most cases, when we have acute abdomen and we don't know what is happening, because we don't know the outcome, probably even there's a perforation, and then if there is a suspected perforation, then the possibility of taking the patient to theater for surgery is possible. So in the initial stage, there may be the need to pass NG tube and then aspirate the stomach content. And when we pass the NG tube, for instance, once we have passed the NG tube, the patient may not be able to eat, and even to take water may be limited. So what we need to do is that it's nail per os. Once we pass it nail per os, we have to instruct the patient, and then we don't need to ask the patient to take any food by mouth. And once we are doing that, then don't forget, you need to resuscitate or maintain the patient on IV fluids, and then we have to monitor the pulse, the blood pressure, and then once you are giving IV fluids, we need to also check the urine output to monitor the intake and then output. And there's the need to re-examine patient frequently if the diagnosis is uncertain. For instance, if the abdomen is flat at a point in time, if we see any enlarged or if the abdomen is enlarging, or if the abdomen is becoming rounded, then we should know what is happening. So we have that as part of the management in terms of non-pharmacological intervention. We have the pharmacological treatment. So here we are looking at resuscitation with IV fluids, or in case where there is a need to do blood transfusion, and then relieve pain as soon as diagnosis is made with petadine. And here we have to give it intramuscular IM. And for instance, adults, we have 50 to 100 milligrams every 3 to 4 hours. And the maximum dosage that we have to give is about 400 milligrams per day. We don't need to go beyond this. Other than that, the patient may be used to it, and that can also cause another problem. And children, 0.5 to 2 milligrams per kg body weight, repeated after 4 hours. And then antibiotics may also be indicated for infections, and then if they are present, and then the following standard may also be used for gut-related infections. For instance, IV IM gentamicin, we have adults and children, 2 to 5 milligram per kg body weight in 3 divided doses, and needed to be cautious about the urine output because of the possibility of gentamicin causing acute renal failure in the early stage. And so do not give if urine output is less than 30 ml per hour, and that is very important. And then in some cases too, we can give metronidazole, which is IV flagyl, which is about 500 milligrams infusion 8 hourly. Children, 7.5 milligram per kg body weight infusion 8 hourly. And then in some cases too, we can give IV ciprofloxacin, adults 200 to 400 milligram 12 hourly, infused over 30 to 60 minutes, may be added for typhoid perforation and then other similar conditions. And in children, not recommended for children, but where benefits outweighs the risk, and if you don't take care, we may lose the child, or the child may die or expire, it can be given. So ciprofloxacin IV 10 milligrams per kg body weight 12 hourly may be given, and then further treatment will depend on the diagnosis and the response to treatment. For peptic ulcer, I have provided you with the nose, and here we have the open sores in the lining of the stomach. We can also have them in the esophagus, and then even in the duodenum, the first part of the intestine. These are the common places. And then the causes of the stomach lining. Here what happens is that we have factors, acid, that can damage the stomach lining, and where that protection fails, an ulcer forms, and these are different ways this can happen. And we have the nose. So I want you to look at, in the first instance, I want you to look at the protective factors of the GIT, and then when these protective factors are not there, or when they are overcome by other factors, then we have the development of the peptic ulcer. And so we think about the cytoprotective effect of the GIT, and when for instance we take antiprostaglandins, for instance we have the NSAIDs like the aspirin and then other drugs. These can disrupt the protective effects of the GIT, and that can also lead to the inflammation and then hyperemic areas as a result of the acid contact of the GIT. And so acid in general may be the possible cause, but if the acid is able to overcome the protective effects of the GIT, that is where the problem occurs. So we have a reflux of the duodenal contents, and then gastric ulcer may also be superimposed on gastric cancer. And then here are the possible areas on the diagram. Let's look at the diagram. We have the fundus, and these are we have the body of the stomach, and we have the duodenum. And then we have specific areas where this condition can occur. And then here too, you can see the ulcerated areas. We can also have them here, even in the fundus. We have them here, and then here too in the duodenum, we have the ulcers. We have the Helicobacter pylori, which is one of the microorganisms responsible for most ulcers. And then we have the non-steroidal anti-inflammatory drugs, NSAIDs, which I've already mentioned. So long use of these drugs is the second common cause of the ulcers. Other causes are also there. Risk factors, hereditary, older age, and then chronic pain. And then as a result, the use of NSAIDs is likely to cause, and the alcohol consumption. Diabetes may also increase one's risk of getting H. pylori. And the clinical manifestations, we have the abdominal pain, and then the pain is often made worse by empty stomach, and then heartburn, which may mistakenly be taken as GERD. And then we also have indigestion, belching, nausea, vomiting, and poor appetite, and then weight loss is also likely to occur. And diagnosis, first take detailed history, which is very important. And then we can also do upper gastrointestinal series, which we have done. Endoscopy is one, whereby a fiber optic device is passed through the mouth and then to the areas that are involved, and then we can do other tests. And then the treatment goals for treating this kind of condition include getting rid of the underlying cause. And so if it is NSAIDs that are causing the problem, then you have to halt it. And the lifestyle, dietary and other lifestyle measures that should help include eat high, a diet high in fiber, and then also need to look at foods that can also aggravate the condition. We have to avoid that. We have different medications. Antacids, we have drugs that can neutralize the acids. And then we have H2 blockers like the cimetidine, ranitidine, and nisotretinoin, and then we have the famotidine. And the acid pumping inhibitors decrease the gastric acid production, and they include common ones that we have is at the hospital we have the omeprazole, and then the other ones. And then we have in cases that we need to treat the H. pylori, we have the amoxil, and then the metronidazole, and then we have the mucosa healing agents like Carafate. And then surgery may be done. Surgery, we are not going to look at it. Next 2, 3, 4, we'll look at that. So I have provided some kind of notes, types of surgeries that can be done. You can read well ahead of time, but I hope your lecturer for next 2, 3, 4 is going to provide notes and they meet you on this. So we have gastric resection, and that we have vagotomy, and then we have pyeloplasty. And then the complications of the surgery, we have the reflux esophagitis, which is likely to occur. and then other post-operatively. And then prognosis and complications are also there. Complications from ulcers include bleeding, perforation, bowel obstruction, and then penetration if interventions are not identified. So bleeding is common complication of gastric ulcers, and the bleeding from peptic ulcer stops spontaneously in about 70 to 80% of patients. And then the perforation is also likely to occur, obstruction, which we have already mentioned. We also have penetration, which is also likely to occur. Nursing management centers on the following: dietary therapy. We have mentioned diets that are specific, that cannot worsen the pain, and that can also worsen the condition. For instance, we have to avoid the intake of alcohol, hot foods, and then caffeinated foods. And then if we suspect bleeding, we have to discuss with the patient, and then identify possible interventions, which is very, very important. For ulcers, we have different names. We have the duodenal ulcer. We may come across gastric ulcer. We may come across stomach ulcer. We have the ulcer peptic, and these are different names that you may come across. I want you to read on gastritis as one of the conditions associated with it. The references are here. You can do further reading and then build on your knowledge. Thank you very much.